Hi, today I'm going to be talking about serotonin toxicity precipitated by tramadol in the setting of polypharmacy, a case report and literature review of serotonin syndrome. This syndrome is characterized by the triad of altered mentation, neuromuscular excitation, and autonomic dysfunction. It's caused by overstimulation of both the central and peripheral serotonin receptors. Often seen in the setting of polypharmacy of multiple serotonergic agents, it's not an idiopathic drug reaction. The incidence is unknown, but the true number of cases is very likely to be much higher than the number reported, considering over 85% of physicians are unaware of it being a clinical diagnosis. This case provides a unique opportunity to observe an opioid tramadol precipitation of serotonin syndrome in the setting of polypharmacy. The patient was a 79-year-old Caucasian female with a non-exclusive past medical history of non-ischemic cardiomyopathy, major depressive disorder, diabetes mellitus type 2 of associated neuropathy, and chronic pain secondary to malignancy, who presented to the emergency department with generalized weakness and worsening tremors involving upper and lower extremities. She reported that the tremors intensified when standing from a sitting position, causing a non-traumatic fall. As per the patient's husband, she had experienced episodic visual and auditory hallucinations. On physical examination, she had altered mentation, tremors, diaphoresis, fever, tachypnea with labored breathing, and 3+ pitting edema of the extremities. She was admitted with a presumptive diagnosis of heart failure exacerbation triggered by community-acquired pneumonia. On medication review, an extensive regimen including several cardiovascular, antihypertensive, antidepressant, and pain control agents were noted. We were concerned with the oxycodone, tramadol, trazodone, and citalopram. Of note, a week prior to admission, the patient had been started on the tramadol. On admission, she was started on empiric antibiotics. Her white blood cells trended down from 13.2 to 10.8 throughout her stay, and her blood cultures are negative, so those were discontinued. Serotonin syndrome was suspected upon review of medications by the hospitalist team. Her tramadol was immediately discontinued, and her symptoms ceased within 24 hours. Serotonin syndrome is a threatening and potentially lethal complication of serotonergic polypharmacy. It is typically the result of the initiation of a new pharmacologic agent or dose escalation of the culprit agent to a medical regimen including other serotonergic agents. All drugs and supplements that directly or indirectly increase central serotonin neurotransmission can produce this toxicity through a variety of receptor and reuptake effects. The diagnosis is made purely upon clinical suspicion since there's no specific diagnostic test. Additionally, patients can have a wide range of presentation from mild symptoms to life-threatening. The clinical triad previously mentioned is what's characteristic, but timing and severity can be altered depending upon medication concentration and patient genetic factors. The syndrome was likely induced in our patient due to the compiled effect of reuptake inhibition of serotonin by oxycodone, selective reuptake inhibition of the same by citalopram, and antagonism of receptors and inhibition of specific serotonergic reuptake by trazodone, aggravated by the addition of tramadol, triggering the acute toxicity in our patient. Most patients typically come to the hospital within 6 hours of medication adjustment, but this patient was not hospitalized until 11 days after treatment initiation. Patients with a mild presentation are typically afebrile. Even though this patient had a milder form of the syndrome, she still had a fever, which may have been influenced by her history of inflammatory illnesses, making her body more prone to fight off adverse reactions. Of note, serum serotonin concentrations have no correlation with the severity of the syndrome. Additionally, even a single therapeutic dose of an SSRI agent can induce the syndrome. Cessation of the serotonergic agents is the mainstay of treatment, and this diagram just shows some examples. It's important to recognize serotonin concentration in our patients because many healthcare providers will encounter this iatrogenic diagnosis during their careers. Clinical diagnosis of serotonin syndrome is challenging due to the syndrome having a wide range of presentation. This patient had a mild course but was still febrile. She had multiple factors in her history that may have influenced her presentation, including inflammatory illnesses, as well as being on a SSRI and a SARI, concomitantly with an opioid. The addition of tramadol was the tipping of the scale. This is unique because as healthcare providers, we don't often associate opioids with serotonin. A note on patient safety, we know that from mid-year 2019 up to now, 5 different physicians had prescribed controlled substances to this patient, and she was hospitalized 3 times. So when prescribing controlled substances, make sure to do a thorough history on your patient, including medications prescribed by other providers. Thank you.